This is part of a series that we provided to the OSU Internal Medicine house staff as well as to the providers that are caring for COVID-19 patients. We all know that the arsenal of what we have available to us to treat COVID patients is changing pretty frequently. Some therapies that we were told were going to be tried and true obviously turned out to not be tried and true. One of the therapies that we want to focus on, because there is still a lot of information that's being collected in regards to it, is the use of convalescent plasma. And so this brief lecture is going to be focusing on the use of convalescent plasma for patients who have COVID-19 infection. So I am briefly Mousumi Som. I am a practicing internist. I've been in practice for almost 15 years, and I am currently serving as the chief of staff at OSU Center. So what is convalescent plasma? And how does convalescent plasma work? In essence, it really works by achieving immediate short-term immunization against infectious agents by administering pathogen-specific antibodies. This is done by extracting plasma from recovered patients and then transfusing them to infected COVID-19 patients, which essentially means that you're taking antibodies from somebody that's recovered from COVID-19 and you're giving those antibodies to an individual who is currently infected with COVID-19. The use of convalescent plasma collected from previously infected individuals to passively transfer antibodies in order to protect or treat humans actually dates back almost 100 years, with some evidence against rabies, hepatitis B, polio, measles, influenza, Ebola, and other pathogens. Results from a small case series during the prior MERS and SARS coronavirus outbreaks documented safety and faster viral clearance following convalescent plasma administration, particularly when given early in the disease course. I really want to emphasize given early in the disease course because that's something that we'll talk about later on in the slides after we're reviewing some of the literature that exists for CPP for the treatment of COVID-19. There was a 2015 systematic review and a post hoc analysis on the effectiveness of convalescent plasma for the treatment of SARS, reported to be statistically significant with a reduction of about 75% in the odds of mortality among SARS-affected patients who were treated in comparison to those who received placebo or no therapy. So what is really the evidence backing convalescent plasma? Because as you know, we live in a world where we really need to have evidence-based medicine. We shouldn't be just giving therapies without any type of rigorous trial or control to determine whether the risk outweigh the benefits. And in fact, the treatments are doing something and we're not just essentially administering placebo. So the next three trials I actually tried to break down in the same manner so it's a little bit easier to read. And these three trials were the first three trials that came out looking at convalescent plasma in the treatment of COVID-19. I use the word trials a little bit loosely because you'll see that the number of patients that were included in this are very, very small. The last trial that I talk about was a much larger trial and was actually one of those trials that you really want to look at when you're vetting evidence, because these three really weren't double-blind, placebo-controlled, randomized studies, but they did give us a general indication of, is this something that we should really be looking at? So the first trial to come out was published in JAMA and had 5 patients. You can see the patients were all older, and some of the highlights shown here when you review this graph is that 3 patients were extubated within 9 days post-transfusion. All patients had a decrease in their SOFA scores by day 7 post-transfusion. Viral load decreased and all were negative by 12 days post-transfusion. All patients had decreased inflammatory markers and all 5 patients survived. 3 patients were actually discharged and 2 were stable at day 37 in the hospital. So again, promising, super, super small study. We shouldn't be making generalized statements about the efficacy of convalescent plasma for COVID with a study that looked at really 5 patients. And again, refreshing your memory, not a randomized controlled study. This was really very much retrospective. So essentially we gave the patients convalescent plasma. Here were 5 of them. They all had severe COVID-19. How did they fare and how did they do? So next study was actually considered a pilot study and it was published in the Proceedings of National Academy of Sciences, and it looked at 10 severe COVID-19 patients between the ages of 34 to 78. So if you flip back to the other side, you can see similar type of breakdown, but really only 1 patient that was in their 30s, and then everybody else was kind of older, really in the 50s, 60s, and 70s. Here you can see a little bit more of a wide spattering of ages, which is good because particularly now we see that COVID's actually affecting a pretty broad population. And now, most recently, what we're ending up seeing is the largest proportion here, at least in Oklahoma, is the ages of 18 to 35. So this becomes a little bit more relevant for us. Enrolled patients in this trial received transfusion of 1 dose of 200 milliliters of convalescent plasma derived from recently recovered donors containing high levels of SARS-CoV-2 neutralizing antibody. And their antibodies were actually measured, at least the titers were measured, and they were above 1 to 640. The majority of symptoms on presentation were cough, fever, shortness of breath, which we hear about most often as far as when individuals present for medical attention, either to urgent care or to a hospital or emergency room. There were a couple with myalgias and diarrhea as well. Within 3 days of convalescent plasma transfusion, clinical symptoms such as fever, cough, and shortness of breath, as well as chest pain, significantly improved, and patients exhibited increased lymphocyte counts, improved liver and lung function, and reduced inflammation. So when we look at SARS-CoV patients, one of the things that we find frequently when they're admitted to the hospital is that these patients have a neutrophilia, but they actually have a lymphopenia. In addition, they usually, when they're super ill, they usually end up having some level of transaminitis. And then they have a lot of inflammatory markers that most studies are actually looking at. So that can be a high sensitive CRP, and ESR, a ferritin, and LDH, and interleukin-6, if those are actually available. And those all indicate pretty high levels of inflammation when they're elevated. The mean time from onset of illness to convalescent plasma transfusion was 16.5 days. So again, you can see there seems to be a little bit of a delay in administering convalescent plasma. Most of the studies that looked at patients that were affected that benefit from convalescent plasma, the earlier you give, the better. And why do we think that is? Why are we seeing such a delay in transfusing these patients when we know that it helps when they're transfused early? And I think the reason for that is really simple. So when individuals become infected, remember, they usually have a 5-day incubation period. When they start developing symptoms and they're tested, they actually have almost a 10-day lag time before they become acutely ill. And we think that's because they have this delayed cytokine response that really takes effect at 10 days when they're, after they've been diagnosed, when they're developing symptoms enough to be seen in a hospital, emergency room, urgent care type setting. So I don't think that individuals are delaying the transfusion. I think when they're coming in, yes, we know they have the diagnosis, but really just based on the course of the illness, it's 10 days after they've been diagnosed that they start developing symptoms, and that's why there seems to be a delay in the transfusion of convalescent plasma. Other important things to know from the study: there were no severe adverse effects that were observed, and really consistent with the previous research, and again, I use that term loosely, all 3 patients receiving plasma transfusion given before 14 days in this study showed a rapid increase of lymphocyte counts and a decrease of their CRP with remarkable absorption of lung lesions on CT scan. Notably, patients who received convalescent plasma transfusion after 14 days shows less significant improvement. So again, very consistent with what old literature has actually shown us about when we use convalescent plasma as a treatment therapy. All patients in this study actually received antiviral treatment despite the uncertainty of the efficacy of these drugs. As a result, the possibility that these antiviral agents could contribute to the recovery of patients or synergize in with the therapeutic effect of convalescent plasma could not be ruled out. Furthermore, some patients receive glucocorticoid therapy, which might interfere with immune response and delay viral clearance. And so I think that's also really important thing to recognize, that administering steroids, yes, we're seeing in some of these studies that convalescent plasma actually enables people to clear virus quicker, but when you're giving concomitant steroids, it might actually delay their viral clearance. So something important to kind of remember as you're treating these patients. So the third study looked at 4 critical/severe patients and was actually published in Chest. Patients in this trial, however, received varying doses of plasma, so a little bit of inconsistency in how much plasma they received, so that can obviously interfere with interpretation of the study as a whole. They observed no serious adverse reactions associated with transfusion of convalescent plasma. Supplemental treatments were again used in conjunction with convalescent plasma, and again, you kind of see some of the same general trends. You know, patient 1 was mechanically ventilated. They ended up getting extubated. Patient 2 was on high flow nasal cannula. They got stepped down to nasal cannula. Patient 4, also on mechanical ventilation and extubated. Patient 3, older, also had severe COVID, and they were on mechanical ventilation. They remained on medical ventilation. You can see that there is conversion, again, very similar to some of the other studies that we looked at, conversion from seropositivity to seronegativity after the transfusion of convalescent plasma. One important thing to also recognize here was patient 4 was pregnant. So really the first time we've been administering convalescent plasma in a pregnant patient. And she really did well overall. As you can see, she was extubated. She converted to negative status of COVID-19. Unfortunately, her baby did die. And I don't think that there was a correlation between the convalescent plasma and the infant's death. I really think that was just a manifestation for how ill she was. So this is the last trial I'm going to talk about, the one that's actually most recent. As you can see, it's been just published within the last couple weeks. This was published in JAMA. It was published on June 3rd, and very, very important because this was the first randomized clinical trial that was performed on patients with COVID-19 with the use of convalescent plasma. So it's important, and it's really kind of groundbreaking. I will tell you, if you're interested, there is a letter to the editor that comments on the findings of this study that I think is well worth a read, but I'll try to encompass what was in this article as well as what was in the letter to the editor to give you the whole picture about how we should interpret this and if it should change what we do or what we don't do. So in this randomized clinical trial, it was about 103 patients. It was terminated early. And I bring that up because I think it's very important when trials are terminated early to determine why they were terminated early, if it was because of a safety issue or whatever the case may be. This one, again, was terminated early. The hazard ratio for time to clinical improvement within 20 days in the convalescent plasma group versus the standard treatment group was 1.40. This indicated that this was not a statistically significant finding for the use of convalescent plasma in patients with COVID-19 in comparison to those that weren't. But what's really important to recognize here, number one, it was an open label, multi-center randomized clinical trial that was performed in 7 medical centers in Wuhan, China from February 14th, 2020 to April 1st, 2020, with the final follow-up on April 28th, 2020. The 103 participants had laboratory confirmed COVID-19 that was severe, so either respiratory distress and or hypoxemia, or life-threatening events such as shock, organ failure, or requiring mechanical ventilation. The trial was terminated early after 103 patients of a planned 200 patients were actually enrolled. Consequently, and this is why this becomes important, if they were anticipating to do 200 patients, but they only got to about 50% of that, this study was 100% absolutely underpowered, and many comparisons between convalescent plasma group and the control group were not statistically significant. Well, how do you say that when a study is underpowered? So remember, when we are planning to do studies, we always do essentially what's called a power analysis, and that tells us you have to have this many patients participate in the study for us to really be able to determine statistical significance. So if you don't hit that number, that study ends up becoming underpowered. So the interpretations that you make from the results have to be taken with a grain of salt. You didn't meet the number that you said you had to meet in order for us to determine if there's truly a significant benefit or lack thereof with our intervention arm. So convalescent plasma used in this study was associated with some clinical improvement in severely ill patients, but not necessarily critically ill patients. Greater efficacy in less ill individuals is expected because antibody therapies generally work best when administered early in disease. We know this from what we've seen in the past. We actually know these from those 3 pilot studies that we just reviewed previously. Historically, antibody therapy was effective in reducing the mortality of pneumococcal pneumonia when instituted in the first 3 days of symptom onset. So again, pneumococcal pneumonia, obviously very different than what we're talking about here, but when used for pneumococcal pneumonia, we know that if you give it within the first 72 hours, that's when you see your significant benefit. And when you go back through these studies, look at these days of convalescent plasma infusion range from day 11 to day 18. Here, again, same thing, day 11 all the way up to day 20. And here, same thing, day 10 going all the way up to day 20. So kind of makes sense. well, maybe we're not administering it early enough. But again, I think that becomes a little bit dicey because you're not sure where they are in their spectrum of disease. And sometimes, yes, they've been diagnosed, but they're absolutely asymptomatic. So do you pull the trigger and give it to them? I think that's something that takes a lot of clinical judgment. But from all of our previous studies, we know administration of convalescent plasma earlier on in the disease process gives you more bang for your buck. In a study by Lee et al., the median age of the patients with severe disease was 70 years, and the median time between symptom onset and randomization was 30 days. Promising results with convalescent plasma treatment in patients with SARS and influenza H1N1 were obtained among younger patients, and in the case of SARS, much earlier in the disease. The importance of a possible treatment benefit in older persons in whom mortality from COVID-19 is markedly higher than in younger persons cannot be overstated. In addition, the apparent improvement in the clinical status of the subgroup of less severely ill patients a month after the onset of symptoms really suggests beneficial effects of antibodies in COVID-19, and they may be measurable as an improvement in inflammatory markers and viral elimination before clinical improvement is observed. So again, administering this sometimes before you see the clinical improvements, you'll actually see a change in the inflammatory markers, which is not super surprising. Sometimes inflammation has to reduce and it has to have a sustained effect before you can actually see the clinical changes. I want to bring up again that this study, median age of the patients with severe disease was 70 years. We know that the disease affecting the elderly is much harder on that patient population than it is when the patient population is much younger, and median time between symptom onset and randomization was 30 days. One last point that I want to leave you guys with is, like remdesivir, convalescent plasma administration was associated with clinical improvement without a statistically significant effect on mortality, with the important caveat that remdesivir was evaluated in a larger study, whereas this study was terminated prematurely and underpowered. For both studies, both remdesivir and convalescent plasma, the importance of clinical improvement as a primary endpoint became apparent as the trial progressed. So we're using remdesivir, and remdesivir obviously it has gotten a lot of attention in the press and is really kind of the mainstay of treatment. I don't think that you can completely disqualify convalescent plasma just because the same findings with remdesivir, hey, yeah, it might not be statistically significant, but there's definitely something here. There's some signals that say that this might be an appropriate therapy. We're seeing the same thing with convalescent plasma therapy. And remember, remdesivir probably much more adequately powered with a much larger sample size than was in this particular trial. I also want to mention that safety here, we've seen, and it's actually been published recently, that safety with convalescent plasma is there. The risk versus benefits with plasma obviously need to be discussed with the patient, but severe actions or adverse reactions, we're not seeing a tremendous amount of those with convalescent plasma by any stretch of the imagination. So what are the general criteria for transfusion of convalescent plasma? Number one, you have to be confirmed COVID-19. It's not for PUIs. They divide it into two major groups, severe or life-threatening. Severe is respiratory rate greater than 30 if the patient's actually dyspneic. If their PaO2, FiO2 ratio off of arterial blood gas is less than 300. If they've had bilateral infiltrates of greater than 50% of the lungs in 24 to 48 hours. And if their O2 saturation is less than 93%. So that would be considered a severe COVID case and can be administered convalescent plasma. And then life-threatening is respiratory failure, particularly as evidenced by mechanical ventilation, septic shock, or multi-system organ failure. There are no restrictions to adjunctive therapy at this time. And by the trials that have been done already, we see that most individuals are actually receiving some type of adjunctive therapy, from antivirals, remdesivir, corticosteroids in ARDS patients, et cetera. Some patients are mechanically ventilated, some are on supplemental O2, some are on ECMO. And so convalescent plasma has been used kind of across the spectrum. So how do I get convalescent plasma for my patient? This, again, is very specific to OSU. There are really two pathways. We are actually utilizing the first and working very closely with Oklahoma Blood Institute because they're local and it's a lot easier for us to receive units, et cetera, from Oklahoma Blood Institute. It still requires authorization from the FDA and it's case by case. So just because you get an EUA from the FDA for one patient, it doesn't mean that you can apply it to all the other patients. It's not a universal IND, and so it has to be done individually for each patient that's getting convalescent plasma. This is a sample of the sheet that you have to fill out on the right, and the questions they ask you in regards to why you want to give patients convalescent plasma. Typically, when you email this request, you'll have a follow-up within 4 hours. If you want to transfuse a second unit of convalescent plasma to the same patient, you do not have to go through the FDA for additional approval. You already have approval for that patient, and you can use that IND for that patient again subsequently. Once you receive authorization from the FDA, again, you get an IND number. You need to send a copy of the IND to the lab at OSU, and this will get sent through OBI through a Form 88, which the OSU lab will help you complete. And so the big question becomes, so how much should I transfuse? Historically, the dosing of convalescent plasma has really been very variable, which may be ascribed to differences by indication. The selected dosing that we're utilizing here was based on experience with previous use of convalescent plasma therapy in SARS, where 5 milliliter per kilogram of plasma at a titer of 1 to 160 was utilized. So for a typical patient, which we'll say is roughly about 80 kilos, this would result in 250 milliliters of plasma, approximating the volume of a standard use of plasma in the United States. And so that's why you'll see us transfuse about 1 unit at a time. Remember, because this is a little bit weight-based dosing, you may want to take that into consideration if you have to redose the patient, because they may not have gotten as much benefit as you would have initially thought because of the fluctuations weight. That's something that I think that we need to take into consideration here in Oklahoma because of the rate of obesity that we have in Oklahoma. So what are the risks of convalescent plasma? This is something that you 100% have to be discussing pros, cons with your patient, because they need to understand that they're receiving a blood product. So this is something 100% that does need informed consent and should be completed by the physician. So when you're obtaining consent, what are the risks that you want to discuss? Human plasma transfusion is actually a routine daily event in modern hospitals. The only difference here is the presence of antibodies against SARS-CoV-2. Donors will satisfy all criteria for blood donation based upon federal and state regulations for volunteer donor eligibility and will be collected in FDA licensed blood centers. Therefore, the risks to transfusion recipients are likely to be no different than from those that are just getting standard plasma without antibodies. Risk of transfusion transmissible infection is super low in the United States and other high income countries. Typically cited estimates are less than 1 infection per 2 million. Donations for HIV, hepatitis B, and hepatitis C viruses. Non-infectious hazards of transfusion, such as allergic transfusion reactions, transfusion-associated circulatory overload, which we abbreviate as TACO, and transfusion-related acute injury, TRALI, do exist. While the risk of TRALI is generally less than 1 for every 5,000 transfused units, TRALI is a particular concern in severe COVID-19, given potential priming of the pulmonary endothelium. However, routine donor screening includes HLA antibody screening of female donors with a history of pregnancy to mitigate the risk of TRALI. Of note, risk factors for TACO, i.e. cardiorespiratory disease, advanced age, renal failure, are shared by those at risk of COVID-19, underscoring the need for careful attention to fluid volume management. The likelihood of 1 unit of plasma will make this less of a concern, but really you have to know where your patient is as far as their tipping point. Remember, we try to keep, when we're treating these patients, we try to keep them on the dry side and treat them very much like ARDS, so sometimes 250 cc's, or 500 if you need to give them 2 units could really make the difference in their respiratory status. Specific risks pertaining to human anti-SARS-CoV-2 plasma include transfusion-transmitted SARS-CoV-2. This is really largely theoretical since the recipient is already infected and there's never been a report of transmission of a respiratory virus by blood transfusion. There's no donor screening in effect for common respiratory viruses such as influenza, RSV, parainfluenza. SARS-CoV is not considered to be a relevant transfusion-transmitted infection, and only 1% of symptomatic patients have been reported to have detectable SARS-CoV-2 RNA in their blood. There's also the theoretical possibility of antibody-dependent enhancement following transfusion of human anti-SARS-CoV-2 plasma. Antibody-dependent enhancement refers to a process whereby antibodies that develop during a prior infection exacerbates clinical severity as a consequence of infection with a different viral serotype. The phenomenon is well known for some viruses, notably dengue virus. The largely theoretical risk of antibody-dependent enhancement in COVID-19 would be attributable to antibodies potentiating infection upon exposure to other strains of coronavirus. Concerns about coronavirus ADE stem primarily from in vitro studies using monoclonal antibodies, whose relevance is absolutely uncertain to the polyclonal antibody composition found in convalescent plasma. Nonetheless, ADE is unlikely to be relevant to the proposed use of convalescent plasma in prevention and treatment of a disease with the same virus. Caution is warranted. Somewhat reassuring is the apparent absence of ADE reports with the use of convalescent plasma for SARS, MERS, and COVID-19. Lastly, the one thing that we also want to highlight, because again, this is a blood product that's being transfused, is ABO incompatibility. The number of antibodies present in plasma is very low, so the likelihood of transfusion reaction related to this is very small. Still needs to be discussed with the patient, as this is still a possibility. If the patient refuses to take ABO incompatible blood, we recommend not ordering a unit for the fear of this unit being wasted. And we still consider, even though our blood bank has definitely more stock than has been in the past, we still consider this a precious commodity and don't want to be wasting blood products in this time. So this is a little bit of information in regards to donating. Individuals who want to donate really need to access the website that OBI has placed. And so OBI has a website that you can go to. And so if you just go to obi.org, you can click on that website and it'll give you a step-by-step process of what you need to do in order to donate plasma. So these are for patients who have COVID-19 and they've recovered. Important things, and we'll talk about this in the next slide, is if you've received convalescent plasma, you are ineligible to donate convalescent plasma for up to 12 months. But not everybody, remember we talked about severe and life-threatening, those are the only patients that currently we're giving convalescent plasma to. And so if you have not kind of hit that point and you're kind of a mild to moderate and you never received convalescent plasma, then you are eligible to donate to OBI to help them increase their bank. Again, where you need to go is to obi.org and they will walk you through a step-by-step process. They have multiple centers throughout Oklahoma, so it makes it very easily accessible. An important thing to know is that 1 unit of plasma donated can be used for approximately 3 patients. So you can see how this donation becomes very valuable and 1 unit can affect many. We're here at OSU, we've been very proud to work with our local blood bank at this time so we can ensure that donated units will be returned back to patients within Oklahoma. So just briefly, a couple of frequently asked questions. One is, can I donate more than once? Yes, you can donate more than once. So if you are a patient that's recovered from COVID-19, you've got antibodies that have been detected, you can donate more than one time, but you have to wait 28 days before you can go back to donate again. And then, like we'd already mentioned, if a patient has received convalescent plasma, can they donate? No, they can't. Transfusion must be donated, must be held as far as donations for up to 12 months. And so immediately after receiving convalescent plasma, you have to wait 12 months before you're eligible to donate. So this was just kind of a brief overview about convalescent plasma as a treatment modality for patients that have been affected by COVID-19. We are still waiting to see what the results show from the Mayo Clinic that has been looking at convalescent plasma with the Red Cross. I suspect that that information will be very, very telling because they've been very rigorous in their controls in regards to collecting information. And so it'll be good to know as far as safety is concerned and also to see whether it has benefit. I think the things that we need to keep in mind are severity of illness as well as time to transfusion after symptoms develop, because we are seeing that the earlier you administer convalescent plasma, the more bang for the buck that you actually have. So that completes this lecture, and we will continue to keep you posted as we know more.